So now we move on to arteriosclerosis. This is super high yield. Pay attention with everything you have because the board examiners absolutely love this. Now the arterio indicates we're talking about arteries, and sclerosis indicates that there is some sort of hardening going on of the vessels that we are interested in, which are our arteries. So what about arteriolosclerosis? We added some letters in here. So by adding this L and O, it means that we're now talking about the smaller arterioles. There are two types of arteriolosclerosis that we need to know about. Number one, it's hyaline arteriolosclerosis, and this can occur in hypertension or also in diabetes mellitus. So here's the first image that we're looking at. Do you see the pink material that is thickening the vessel and narrowing the lumen? Here's the very tiny lumen. These blue arrows are pointing to this pink material. The term hyalinosis comes from the glassy and pink staining material here in the vessel lumen. When we stain it with hematoxylin and eosin, it appears very pink. In hypertension, the high pressures will literally pound proteins into the basement membrane. So the basement membrane that the endothelial cells sit on is being damaged from these chronically high levels of pressure pushing plasma proteins into the basement membrane. This basement membrane disruption leads to a response from the endothelial cells. What do the endothelial cells do? Well, to reinforce the basement membrane because of this chronically high pressure they're subjected to, there's going to be an increase in collagen deposition. And then guess what stains pink on H&E? Hematoxylin and eosin staining. This collagen that's been depositing in response to the high levels of pressure and the proteins that are being pushed into the basement membrane. So what about the hyaline arteriolosclerosis that you see in diabetes mellitus? The same result happens, but instead of the shear forces driving proteins into the basement membrane and damaging that way, the high levels of glucose will lead to non-enzymatic glycation of proteins. What proteins are we talking about? The proteins that sit on the endothelial cells. This leads to formation of reactive oxygen species. Guess what reactive oxygen species do? They damage the endothelial cells. And when endothelial cells are damaged, they dysfunction. So these dysfunctional endothelial cells can actually start to release a lot of cytokines in response to the damage they're undergoing. So they tell fibroblasts to make more collagen. And guess where the collagen is going to be seen on your H&E stain? It's the pink glassy hyaline material in the middle. This is a different pathologic process, but we still get our pink staining collagen narrowing the vessel's lumen. Now the other type that we need to discuss is hyperplastic arteriolosclerosis. This is seen in settings of severe hypertension. People that are hanging around 180 systolic and 120 in diastolic pressures is what we're talking about when we say severe hypertension. Now why does this happen? Why does it look like this? So the endothelial cells and the basement membrane are severely damaged in the setting of very elevated blood pressures. The damage leads to a compensatory process in which multiple layers of basement membrane and smooth muscle cells add concentrically. Concentrically meaning towards the middle of the vessel lumen. Note here how there's one basement membrane with endothelial cells on it. There's another basement membrane with endothelial cells on it. There's another basement membrane, and so on and so forth until you can severely decrease the diameter of the vessel lumen, leading to decreased blood flow. Now the layer of this cross-section on biopsy looks just like the layers of an onion. This is where the term onion skinning comes from. So this fibrinoid necrosis is also the result of this process. So fibrinoid necrosis refers to the fact that damage to the vessel wall will allow fibrin to sneak in to these onion skin layers. The fibrin can deposit around these layers and you get the fibrinous necrosis that's associated with onion skinning from very, very elevated blood pressures. Alright, now we advance to arteriosclerosis, specifically Monckeberg. So Monckeberg's arteriosclerosis will hopefully soon only be referred to as medial calcific sclerosis. The name tells us that there is hardening or sclerosis of the tunica media, secondary to something to do with calcium. So for some reason, calcium is thickening the tunica media and making it hard. Here's an image of what's going on in this disease. These are classically referred to as pipe stem arteries because they look like the shape of the stem on a smoking pipe. So the femoral and the popliteal arteries show significant calcification. That's why they're showing up on the x-ray. It's rather obvious from this radiograph that there is something showing up when these x-rays are hitting the calcium in these arteries. There is no obstruction of blood flow because the media is calcified. It's not hypertrophic and it does not decrease the size of the lumen. A 65-year-old man has diabetes and hypertension. What disease process do you suspect in his small arteries? So hypertension uses brute force to slam plasma proteins into the basement membrane and cause damage that way. Diabetes mellitus, on the other hand, uses non-enzymatic glycation of endothelial and vascular smooth muscle cell proteins to cause the creation of reactive oxygen species that leads to basement membrane damage and endothelial cell dysfunction in that way. The end result, though, is arteriosclerosis, which is hyaline thickening of small arteries that occurs in hypertension or diabetes mellitus. So this gentleman is rather unfortunate in that he's suffering from both disease mechanisms, contributing to a small vessel disease. So now we push on to atherosclerosis. Now atherosclerosis is a buildup of cholesterol under a fibrotic cap inside the vessel wall. For every disease, we need to be aware of groups at risk. What are some risk factors for atherosclerosis? Smoking cigarettes, hypertension, diabetes mellitus, all of these cause direct endothelial cell damage. Hyperlipidemia is obviously a risk factor because any type of lipid can deposit in the intimal layer of the vessel wall. Now, older people have an increased risk for atherosclerosis due to the accumulation of deposits over their lifetime. Women over the age of 50 or postmenopausal women are at an increased risk because without estrogen, because the females are postmenopausal, they now get a decreased amount of HDL. Estrogen is key in the induction of the synthesis of HDL. So with less HDL, there's less extraction of cholesterol from vessels transporting cholesterol back to the liver. Now the last is a rather obvious one. If someone in your family had it, you're at increased risk of also having it. So let's write out the pathophysiology of this atherosclerosis. The atherogenic process is one of the more complex and very high yield sections in the pathology section. Now first, we have to somehow start with the accumulation of LDL in the intima. So small LDL particles are strongly attracted to the proteoglycans in the vessel wall. Now if they remain in the vessel wall for a long time, for example, in someone with very low HDL, like our postmenopausal female, these LDL particles will be oxidized. The oxidation process produces reactive oxygen species. These go on to damage the endothelial cells. Now, what happens when you damage endothelial cells? They react. They don't like it. They react by expressing vascular cell adhesion molecule 1 and releasing monocyte chemotactic protein 1. This combination attracts monocytes and allows monocytes to enter the vessel wall directly. Do you think it's a good idea to have inflammatory cells within your vessel wall? Absolutely not. Let's look at this on a diagram. Here, you can see the monocyte in the process of transmigration. This is our endothelial cell surface within the vessel wall. Here is our lumen, and here are the vascular smooth muscle cells in our media. And here we are in the intima. Note here how all of the action is occurring directly under this endothelial cell layer, and it's directly above the media. So when these monocytes cross over and they're exposed to extracellular matrix proteins, they are now converted into macrophages. And what do macrophages do around all of these LDL particles? They start eating up these little yellow LDL particles. Bringing in macrophages is a protective mechanism because they're going to eat up all of the LDL that's been oxidized. This is to prevent more endothelial cells from being damaged. The only problem is that macrophages cannot do anything with oxidized LDL after they eat it. It just accumulates inside of the macrophages, creating foam cells. Eventually, these foam cells are going to explode, releasing large amount of lipid directly into the intima. They also release all of the proteases and inflammatory cytokines that are inside of the macrophages directly into the intima. Not only does that happen, but the oxidized LDL that's released can bind receptors on other macrophages. When this happens, you can start producing tons of platelet-derived growth factor, which recruits vascular smooth muscle cells out of the media towards the intima. And you also get the release of fibroblast growth factor, which tells fibroblasts to start depositing tons of little collagen fibrils. Here and here, you can see there's more here. So now we have dead macrophages spilling out oxidized lipids and cholesterol accumulating in the intima. It's going to be surrounded by fibroblasts that are depositing a bunch of collagen and vascular smooth muscle cells that won't stop growing and proliferating within the intima. So where does this take us? It takes us here. So the image on our left shows us the fibrous plaque on a microscopic level. Now the image on our right shows us the macroscopic view of the plaque in the coronary artery that's running in the epicardium here. The branches are going to be diving deep into the myocardium and also into the subendocardium. So let's focus on the microscopic image because that is where most of your questions are going to come from. So again, we have our fibrous plaque, and you can see these LDL crystals in here. They're surrounded by very pink staining collagen. Remember, when macrophages explode, they release fibro growth factor and fibroblasts start depositing tons of collagen in the intima. What are the complications? Well, the complications are going to be from a decreased luminal diameter and all of the good thrombogenic stuff that's sitting in this core. This fibrous cap is all that's keeping the blood within the lumen from being exposed to all the thrombogenic contents of the fibrotic capsule. So in addition to the stenosis of the lumen, the presence of this plaque can actually disrupt the diffusion of oxygen and nutrients to the vessel wall. There's no way oxygen can travel through all of this stuff to supply the vascular tissues of the vessel wall. So this leads to intimal and medial atrophy and necrosis. When you have atrophy and necrosis of 2 layers of your vessel wall, you get a very weak vessel wall. And what does that do? It sets you up for risk of aneurysm formation. This is particularly high yield in the abdominal aorta, below the level of the renal artery bifurcations. This is where we have the highest risk for developing aneurysms. This is because abdominal aorta below the renal arteries does not have vasa vasorum. In the aortic adventitia layer below the renal arteries, there is no vasa vasorum. That is the reason for the greatest risk of having an abdominal aortic aneurysm.